You need community trust. In the pandemic, if you use infections, hospitalizations, and deaths, the countries that were most successful were the countries that had high levels of interpersonal trust and had trust in government. That was the strongest factor associated with having good outcomes. What the pandemic does is shows you the good and the bad of what exists in society.
Welcome to The Other 80. I'm Claudia Williams. We will be processing and discovering the lessons from the COVID pandemic for decades to come. So I was really interested to sit down with Dr. Tomás Aragón, the director of the Department of Public Health in California, who led the nation's most populous state through this challenging period. What he learned guiding the state through the pandemic might surprise you. While public health specializes in a lot of technical things, like vaccines, infectious diseases, and labs and tests, Tomás says its deepest power lies in the ability to help diverse groups reach consensus under great uncertainty. Tomás and I talked about how California redeployed an army of census workers to battle COVID, the biggest opportunities AI could bring to public health, and the book he wants to write about public health leadership. So please welcome Dr. Tomás Aragón to The Other 80. It's so wonderful to have you on the show, and I'm really looking forward to this conversation.
Thank you. My pleasure.
What is important for people to know about you?
Well, I was born and raised in San Francisco. I grew up in the Mission District. My family immigrated from Nicaragua in the 50s. I ended up being raised by my mom. She raised four of us as a single mother, and she worked as a seamstress. So that's the kind of upbringing I had. Whenever I think about my work, I always try to remember my mom as sort of an example of, if I'm doing good public health, that's going to be helping people like her.
What's something that you really deeply learned from her?
So my mom was incredibly, incredibly humble. She only had a sixth grade education, but she worked really, really hard. I remember one time I would ask her on her birthday, I'd say, what do you want for birthday? And she would say to me, the only thing I want is for you to be a good person. That's it. And so that's how I was raised. I was raised with just be a good person. That was the only expectation she had. And that made my life a lot easier because I didn't have these external expectations. And for me, everything was an adventure. And I noticed as I went higher in education, I was around other students who were very stressed out. And for me, it was just everything was an adventure because I didn't know what to expect. And so I think having that really helped me feel free to explore, but also not feel external pressures.
Before we dive into public health specifically, one of the things I love about you is that you narrate your work. You have a blog. And not only that, but you have a blog on GitHub. And I think that concept of sharing what you're learning and seeing and experiencing out loud is such a wonderful trait, especially in public health. I'm curious, what was it that prompted you to do that?
So I think writing helps you clarify your thoughts. And then when you put it on a blog, it allows you to put it out there more publicly. I spend the vast majority of my time doing, public health and administration. And people may not realize that I think about other things because they don't always come up. So I try to share that. If I had more time, I'd write a lot more. So there's a balance. I try to keep up a little bit.
Let's say 5 meetings were canceled and you had like 2 or 3 hours free. What would you write about right now? Like, what's on your mind?
So right now, I have an outline for a book on basically public health leadership. Is what it's about. There was a point early on in my career, I would say I focused more on myself, building my career, getting training, writing grants, publishing papers, things of that sort. And then when the health officer position became available in San Francisco and I was recruited for that position, I had a shift in my priorities. I thought, okay, my role now is less as a thought leader by writing papers. My role now is as an organizational leader. And if I can transform the organization and the people under me, they will multiply and amplify and accomplish many times more than I ever could in my individual career. Rather than being a quarterback, I started thinking of myself as a coach, coach that thinks about the whole system of how do you develop players, how do you get them to get better. I would say that that's the journey that I've been on, is focusing on how to be an organizational leader, bringing with me the tools and skills that I picked up along the way. The other thing is to really appreciate the importance of human psychology. It's so incredibly important. It's like you get the vast majority of problems and accomplishments comes from understanding human and social psychology. You're going to come up against people who are going to quote unquote resist. I don't think of it as resistance. I just think about it, they're being human. That's just all it is. People have variability in how they process information, how the core beliefs that they've developed over time. And so rather than seeing things as resistance, you really just see it as part of the diversity of ingenuity that exists in an organizational culture. How do you align it when it's right? But then how do you maintain the diversity and innovation? So it's sort of trying to create that right balance.
I'm a very beginner studier of Buddhism, but the concept of a person who you're in conflict with as a teacher, who's a precious jewel that is offering you something that you can learn, is, I think, a really helpful construct. And also, I think the way you describe it, it gets you out of a reactive mode into an absorbing mode and a learning mode about what's actually going on.
Just to point out, you mentioned Buddhism. So Buddhism, I'm not a Buddhist, but Buddhism is interesting from a neuroscience perspective. I don't know if you know Lisa Feldman Barrett. They did a blog entry on her book, How Emotions Are Made. And it's a great book because most people misunderstand the whole concept of emotions. But by studying emotions, you learn how the brain actually works. And so what she points out is that a lot of the things that they've learned from neuroscience and the study of emotions, you can find actually the things that they discovered, you can actually find in Buddhism. So she has a whole article about how Buddhism from a neuroscience perspective is very accurate.
We could spend the whole hour on that, I think. I want to take us back. You were San Francisco's public health officer until 2021 when you assumed the role as director of California Department of Public Health. So you guided a major U.S. city and then the largest state through the pandemic. And I think a lot has been written, certainly about the lessons from the pandemic. I'd love to hear what lessons have really stuck with you.
Boy, that's such an amazing question. I think a lot of us are still processing it. And actually, it's interesting that George Bush read a book on the influenza pandemic, the 1918 influenza pandemic, and he went back to the White House and said, "We have to be prepared for a pandemic." And so there was a lot of activity during that time on preparing for a pandemic. And then H1N1 happened in 2009, and so there had been all this preparation happening, documents written, playbooks, and that's pretty much the playbook that influenced early on when this pandemic happened. You flatten the curve, so you delay people getting infected until you learn about the virus, have therapeutics, and have a vaccine. That was sort of the playbook that most people used. So let me start with that.
Let me ask a related question, which is, and this came from somebody I interviewed recently. She said, these moments of disruption that are so painful and can be so harmful. And she mentioned COVID. She was also talking about reproductive rights. She talked about Dobbs. She said they can be portals to a better future in the sense that they open up more possibilities for quicker change, for disrupting the way we always operate. And I think telehealth obviously is an example that lots of people bring up. What other ways in which do you feel like that period was a positive portal about demonstrating that change was possible quickly beyond telehealth?
When the pandemic first started, very initially, I would say most people were thinking about it from a more narrow perspective of an infectious disease threat. None of us were trained for how we would do a shelter in place or a stay at home order. It really requires everybody has to be on board. It's really an all of community, all of government, all of state response to do something like this. For example, if you're asking people to stay at home, well, what social safety nets do you have for people who are not going to be working? What are we going to do in terms of access to medical care because they may not feel safe going to a facility for an outpatient visit? It mobilized really all of society. In San Francisco, we had thousands of people mobilized. In the COVID command center at Moscone Center, we had over 500 people. This
Wow.
big operation running the response just in San Francisco. So imagine that now this is happening across the world. People have this misconception that a health official just wakes up and decides, I'm going to do X. That's not how it happens at all.
I think what you're saying is that one of the positive things that emerged was structures that didn't exist before to mobilize that everyone together decision making.
Yeah, so you need community trust. So the nations that were most successful in the pandemic, if you use infections, hospitalizations, and deaths, the countries that were most successful were the countries that had high levels of interpersonal trust and had trust in government. That was the strongest factor associated with having good outcomes. And so that's the challenge. And so what it does is that you learn what the pandemic does. It shows you the good and the bad of what exists in society. It shows both of those. For example, in many of the Asian countries like Japan and Korea, mask mandates were not required because the recommendation of a mask was just everybody would just do it. That plays out differently in different places. So one of the big lessons is that in order to really have an impact, people have to be on the same page. They have to be united, and that can be hard to do. As you can see, things started fracturing in the United States. It's hard enough on the public health community, on the community in general, to respond, but we really need public health officials to help us, to bring us together. And yes, we learned how to build better data systems. We learned how to link case data, hospitalization data, death data. We were able to implement mathematical modeling and prediction. So we did a lot of predictive analytics in the state. The ability in the US to develop the mRNA vaccine is a big story in and of itself. And these amazing accomplishments that occurred because there were investments that were ongoing. You have fast computers. You have people who are capable of doing this. They're able to take data and figure out how to develop good predictive models that they can update with new data. And there were areas that were really difficult. So, for example, vaccine equity. We were able to produce a vaccine quickly, but the distribution of it in an equitable way across the communities around the globe that really required it didn't happen. So there was positives and negatives. And we've learned a lot, and we're bringing all this wisdom. I feel like we're much better prepared if something else were to happen, because in a sense, SARS-CoV-2 is, if you had to design a virus that could just cause a lot of problems, this would be the virus.
We're here in February of 2024, and looking forward for the next year, the next 5 years, what do you see as the biggest priorities for your team looking at California and where it is from a public health perspective?
Yeah, so there's two ways that I think about this. One way I think about it is just internal as an organization, what we do, CDPH. We have over 4,000 employees. doing a really good job internally, making sure that what we do internally is the best that it can be. So we run the WIC program. We have maternal child adolescent health. We have home visiting, tobacco control. We regulate radiation medical devices across the whole state. We license and certify over 12,000 health facilities. So there's a lot of stuff we do that touches Californians. Let's make sure that we do that the best we can. When I speak to the legislator, I always tell them public health is not healthcare. And I say there's 4 pillars of public health. The first one is ecological, social. So what's happening globally affects us here. So we have to pay attention to that. A great example of that is you're seeing this with extreme weather from climate change, as well as COVID. The second one being life course and intergenerational and historical processes. The life course and intergenerational is really important because early life experiences determine the trajectory of a life course, and that life course connects to other life courses because they quickly become caregivers and parents and families. And so it's important for us to connect the dots for folks because people don't always realize that those early life events can lead to chronic disease, mental illness, substance abuse, homelessness, all these things later on down the line, and we need to connect the dots. The third bucket is prevention, especially primary prevention. And then, of course, we have the whole area of equity, anti-racism, and health equity. So those are 4 pillars. And so using those 4 pillars, you think of what are the big public health challenges that we have, things that many of which are going to require more than public health. And of course, climate change is the example. And so in California, I would say, I'm looking back just at the past 10 years, my life in public health has completely changed around responding to disasters because we're responding to fire, air quality, flooding. We have the mosquito issue that happened with a lot of the flooding resulted in a lot of mosquitoes, the heat waves. And so this is the number of disasters that have happened has kept public health activated for the longest time. And then COVID came. And then we had Mpox. And there was, remember E. Valley, the lung disease from people vaping. We have sort of these regular things that are happening. Then you have these disasters, and then you have this pandemic. So public health has been working like crazy for the longest time. And we don't control all the resources. We're trying to manage and bring together the people to help them understand what needs to get done. But ultimately, it's a collective response. It's a collective response.
In 2021, when you were in San Francisco, you and colleagues wrote about a decision-making framework you had used there. And I'd love to have you describe that framework. And then in a minute, we'll talk about the unit you're developing within CDPH focused on decision-making.
Yeah. So in March of 2020, we were watching what was happening, of course, in China, but also in Italy. We saw the number of infections, the hospitalizations, the hospitals being overwhelmed with infections. We were learning from modelers about the doubling time. And so we had to make a decision of what we were going to do. At that point, the Bay Area health officials came together, and we tried to be as coordinated as possible because people live and work in different areas, and we wanted to be unified in our approach. And at that time, we had worked with lawyers and elected officials in terms of reducing the amount of gatherings that occurred, especially indoor gatherings. And so we realized what's left, what's in the playbook that we haven't done that may prevent transmission and save lives just based on everything that we're seeing happening in other parts of the world. And the two major things that had not been done was universal masking and then a stay-at-home order, shelter in place. And so we got together and we had an intense deliberation about whether this should be done, how we should do it. We decided that it was the right thing to do, and we had to engage a lot of legal folks. Everything officials do, if you do something like this in an emergency, it has to be constitutional. There has to be a legal framework. You can't just do what you want to do. and there's always constraints on what you can do. So you have to involve so many people, including elected officials, because the ultimate power is in elected officials. We have temporary emergency powers. So we had decided to do that. And it worked because we had a team of people that over the years, we had developed a lot of trust. So we were able to have honest, vigorous deliberation. And a lot of times people go back and say, well, the 1,000 times this has happened before, what outcomes occurred at what probability distribution? Well, the last time something like this occurred was in 1918. So really, it was decision making under deep uncertainty. And so, as I started reading about this and understanding this approach, I learned about the max mini principle, or some people call it the mini max or max mini. But what it is under deep uncertainty, you get people together and you say, okay, what is the worst thing that can happen? Can we all agree that we can prevent the worst thing from happening? And if you do that, you can usually develop some consensus. We were seeing this happening in other parts of the world, and we realized that it was going to happen sooner or later. But if we waited too long, we'd have too many people infected, and we'd have the hospitals overwhelmed, like what happened in New York City, and we'd have a lot of preventable deaths. And so we realized that we had to act early. So there was a deep uncertainty. There are the trade-offs, and then there's the time constraints. And that's sort of the challenge. And so there's deep uncertainty, for example, in climate change. They're using this type of approach in climate change. How do we design strategies today that are going to be robust to the possible worlds that can occur in the future? Our time runway was so short. And I think that's what made it more difficult was a time constraint. And so getting everybody to buy in to support this was a lot of work.
It's interesting too to think about, as someone with public health training, but wasn't in a public health role. And the part that felt very embraceable was the initial decisions around masking, around isolation. I think where things got harder to understand was where do we start releasing those constraints? And I think that proved to be a harder set of constructs. And different jurisdictions across the country grappled with that very differently. And maybe it was harder to have consensus at that point even.
Yeah, so we'd have to sort of figure out how we're going to get ourselves out of this. And when we first started, we thought, we're going to be here a few weeks. We'd be here for a short period of time. We'll be able to control it down to, get it down here. And then we'll use what we learned to sort of control it. And so initially I thought, okay, yeah, we have people using masks. We were able to suppress the curve. But what the curveball that was thrown to all of us is that this virus continues to evolve at such a rapid pace. And so the virus at the beginning of the pandemic was very different than the virus that we're facing today. So the public health interventions that we were doing, things like case investigation and contact tracing, we'd have metrics of success. Those metrics kept going down and down and down. Even though we had developed more and more capabilities to do it more efficiently, the virus kept evolving. Shorter incubation period, became much more transmissible. The pre-symptomatic infectiousness before the developing symptoms, and then, of course, asymptomatic infection. So the virus is sort of interesting because what a virus wants to do, it wants to spread and not kill its host. Okay? It wants to spread and not kill its host. But if it makes the host too sick, then the host is going to stay home. It won't spread.
Right.
So this is a challenge that we have. So if you have a disease that is only infectious when they're symptomatic, that's a better situation. That's what happened with SARS-1. People were not infectious until they were late into their symptoms, and usually when they were very, very sick. So by that time, they were either at home or they were in a hospital, and the people who became infected were the healthcare workers. SARS-CoV-2 was very different in that there was pre-symptomatic infection and a lot of asymptomatic infection. And so idea that a virus does not want to kill its host only makes sense under that first scenario, when it only transmits when it's symptomatic. Okay. When it's able to transmit asymptomatically or pre-symptomatically, that's where it gets its bang for its buck. It's able to get many people infected during that period of time. In that scenario, it does not care whether it makes somebody sick. In the pandemic, we saw that the Alpha variant and then the Delta variant made people sick, and then other variants did make people as sick. And so from our perspective, from an ecological perspective, this is a scary virus because it could evolve to be more virulent, to cause more disease and death, because it doesn't have that incentive not to, because it's able to efficiently transmit when people are not sick or where they don't have symptoms. So that makes it a bigger challenge for us from a public health community. And that's why the surveillance and the whole genome sequencing and all of this is really important, because another one could evolve that not only is more transmissible, but is more harmful, more virulent. So it can happen. It's already happened. Fortunately, it's become more transmissible and it's been able to get around immune system, but it hasn't become more virulent. And so cross your fingers that's how it stays. But it can go the other way, and that's one of the concerns we have.
You touched earlier on the partnerships and collaborations that developed with community groups, amongst decision makers. Also, as somebody involved in data and technology at the time, I saw a lot of really exciting new citizen-led efforts, collaborations between public health and technology experts and folks like that. What did that mean for the ability to respond to the pandemic? And which of those things have persisted, or are you trying to build out even more today?
I would say in general, that in the United States, we were not able to leverage the technology as successful as, for example, as countries like Korea and Japan. So they were able to use technology much more successfully and quicker than we were here in the United States. We're still trying to build a bullet train, right? You go to Japan. I was in Japan over the holidays, and we traveled to 7 cities throughout all of Japan, all public transportation. We're not there yet. One of the things that we did that I think was really exciting from the state level is that because of the census 2020 census, we had an army of workers that worked across the state for the census. So these were people from the community, working in the community, able to know the community, able to go door to door. So we had this experience of being able to do that kind of work in the community. So when COVID happened, the governor's office was really innovative in saying, we have this incredible network of people across the state that know their communities, from a linguistic perspective, cultural perspective. And so the governor's office leveraged that network, and that became one of the real strong foundations on how everything was done. So around the vaccine rollout, everything was done. The people who ran the census operation became the people that ran. They called it Vax 58. Was the name of the program for all of California. So we really had a lot of boots on the ground, this incredible network and community engagement. And there's just a lot of work happening. And it was, I would say that had a big impact. And I think that was really exciting because at the end of the day, this is not enough. At the end of the day, right. It's really about who are the trusted people in the community, and how do you reach them? And that is incredibly hard unless you already have established relationships. So a lot of it was about leveraging established relationships.
I love how that ties back to the relationships that you had in San Francisco among the different counties, or the investments that have been made into the mRNA, or, all of these shadows of investment that paid off or that didn't pay off because we didn't make the investments as well. Still on this technology theme, I was able to interview Ziad Obermeyer yesterday about healthcare and AI, one of your fellow faculty at the School of Public Health. And what's really been on my mind is how easy it will be and how tragic it will be if the safety net in public health is left behind and we are left with great innovations in AI that do things just around medical care. And so I'd love to just get your ideas and thoughts for what are the public health use cases for AI that are most exciting, and where do you see some of those things taking root or getting experimented on across California?
Big question. Yeah. So I'm, of course, not an expert in artificial intelligence, but when I think of artificial intelligence, I'm thinking sort of two buckets. One is the classification. So being able to classify something and doing it at a high accuracy. And then there's sort of the generative AI. And so we'll definitely have a big impact in healthcare. So in public health, we license and certify 12,000 facilities. A specific inspector can't carry around all the laws, but now with generative AI, we'll be able to sort of mine the laws and being able to customize it and do it over time, do it in such a way that we treat everybody equally and fairly. And there's less variability from inspector to inspector, because inspector is going to put something being as out of compliance based on what they can remember or what checklist they have. Well, that checklist they have can now be a computer that can have a really comprehensive checklist. It can make sure that things are done in a more uniform way. So it's going to have impact like that. So the other area I was thinking about, and this is a real example that came up recently, and that is when we're getting community input. We had a recent project where we had people ask us questions, and we got thousands of questions and comments. And so how do you process all of that information? A team can go through and read each one, and we can classify it, but it's not going to be efficient, and there would be variability depending on who's doing it. And so we realized, oh, you know what? Something like generative AI can go through this data, and summarize it at whatever level that we need, because we need the community engagement, but it's hard to process all the information that's coming in. But if we can do that, we can identify what are the key themes that's coming out from these 2,000 questions and comments. That's going to help us more efficiently respond to people, because otherwise we get overwhelmed and we're not able to do that. And we make sure that as people start using these AI tools, it activates us, and we have to sort of figure out how do we weave it in so that over time people are learning how to leverage the tool, and they're learning how to be better public health thinkers, think more critically, understand more biostatistical concepts, causal inference concepts. So there's a lot of stuff that we want people to learn, but my concern is that we're gonna learn less of that because we're just going to sort of turn over our brain to generative AI. So we have to be really intentional. So and that means that we have to be really intentional on what competencies we think are important, and then how do we make sure that we leverage AI to help people develop those competencies in the first place. In those query systems, how do we have that interactive that recognizes this as an opportunity to remind people about confounding? Yet one of the other things we're doing, I'll just tell you really quickly. So for our public health folks, we have a public health program on causal inference. We also have a training on causal inference. We also have a training on implementation science that UCSF put together. And they put together this overview implementation science course, and I've been going through it, and it is just phenomenal. It's just amazing. It's just how do you get from evidence to practice in a really concrete way? If an intervention works or doesn't work, we should know why. We should be able to deconstruct and answer that. What works in one community may not work in another community. So the ability to customize an intervention for a community. So that's implementation science. Implementation science is so rich in its approach, but how do we teach people that?
So I recently just less than a month ago, joined Berkeley School of Public Health as the first ever Chief Social Impact Officer. And as Dean Liu often says, if you think about the three pillars of universities being education, research, and impact, this is really focusing on how to increase the capacity and the focus of a university on creating positive change in the world. And so as someone who's thought hard about organizations and leadership, and also has long and strong ties to Berkeley, what advice would you give about how schools of public health, and specifically Berkeley School of Public Health, can have more impact in the world?
In general, the way the School of Public Health, I think, could help is that I think there's a disconnect between the generation of evidence and the implementation of evidence. Big disconnect. Academics moves too slow. They move way too slow. And the way for them to learn how to move faster is to somehow be connected to us or another organization so that they develop a practice of evidence generation, and they iterate and they figure out how do they implement that more quickly. And they have to be, in a sense, they have to be with us. They have to be embedded with us. We have people that come back, they come back and they have a 4-hour workshop with us. They come back 6-8 months later. Here's the model we developed. How can you use it? I have no idea. It would have been better if you had been embedded with us and you see the kinds of challenges we're facing, and you go back and develop a minimal viable product on what we're doing, see how that works, and just iterate over time. That would be more effective. So that's just one area that you have to be connected. Otherwise, the public health practitioners, things move too fast. We have to make decisions. We can't wait. We have to decide now. So we have to figure out this working relationship. The second thing is that in governmental public health, we represent everybody, regardless of their religious or political or whatever identity they have. We represent everyone. And so that means that oftentimes in public health, people are taught a lot about advocacy and less about inquiry, which is learning you mentioned earlier. And I don't know if you know the fifth discipline by Peter Senge. He has this whole idea of you have to have inquiry. Inquiry is really important. And it's so true in public health because we represent everybody. So if I'm an advocate usually comes to the table with, I have the solution. Let me figure out how to convince you to implement the solution that I've decided or we've decided is the right solution. And that doesn't always work for government public health. Our approach is to sort of empty our cup and to go in the community and understand what are your needs from the multiple perspectives that you have. And then how can we work together to develop a shared vision of health, and then work towards that regardless of your political affiliation, regardless of your religious affiliation. And so it's more of an inquiry, it's more of a humble inquiry approach. So I think the whole idea of, and you probably know about the whole concept of cultural humility, the whole concept of humility is really critical. And so that means that we have to come with an open heart and an open mind, develop alliances with people that think differently than us in order to make progress and build trust. And so I would say that's the other thing, is that we have to build trust. You have to be willing to build relationships with people who you otherwise completely disagree with. That's hard to do, but that's what's required for governmental public health. Again, because we serve everybody.
But I also think that goes back to both what your mother guided you on, which is to be a good person, and your comment about how much of being effective is understanding human psychology, right? Being in an inquiry-based approach creates a very broad and wide platform for finding areas of agreement, whereas coming with a specific outcome in mind is very fragile. It's very brittle. So I think it actually is just what works in making change.
Yeah, so I think it's really important for students to have that mindset. What the intellectual humility and general humility and cultural humility does is that it supercharges your learning, and you will just learn so much more when you entertain other people's perspective and other ideas. Because people, what they do is they come at each other like this, trying to convince the other person, I'm right, you're wrong. But what happens is that people yell at each other, they shut down, people become more polarized, people start othering other people. One of the things I learned from other people that have worked around the world in public health issues that sometimes can be very divisive in communities, like in HIV prevention, for example, that you have to come with a mindset of an open heart and an open mind and listen to everybody.
What a beautiful place to close. And I just am so grateful for your insights and time today. Thank you for joining.
Okay. Good luck, Claudia.
I came away thinking about how lucky we are to have a public servant as open-hearted, people-savvy, and yes, geeky as Dr. Aragón. I have deep respect for the work he's doing, and I want to see incredible people like him stay in public service. But we're making that job incredibly hard. They are attacked, they receive death threats, they are undermined, and we are seeing scores of brilliant, committed public health leaders depart the field permanently. So one of the jobs we need to task our elected officials with is how to support, protect, and yes, occasionally challenge these vital public servants. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Tomás Aragón and the California Department of Public Health. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.